This is the Whole Care Network. Helping you tell your story one podcast at a time. Content presented in the following podcast is for information purposes only. Views and opinions expressed in this podcast are solely those of the host and guest and may not represent the views and opinions of the Whole Care Network. Always consult with your physician for any medical advice, and always consult with your attorney for any legal advice. And thank you for listening to the Whole Care Network.
This is Sarah, and I just want to take a moment to speak to you about this week's sponsor, Favor. Favor Inc. is a statewide family-led nonprofit 501c3 organization that is committed to empowering families as advocates and partners in improving educational and health outcomes for our children. Favor is the Connecticut state organization of the Federation of Families for Children's Mental Health. Favor offers a single place for families with children who have medical, mental, emotional, and behavioral health challenges to find information, assistance, and training. To find out more about Favor, please go to favor-ct.org. We are grateful for our opportunity to work with Favor as a sponsor, and now on to the rest of the episode.
This episode is brought to you by CogniView. CogniView provides cognitive assessment tools to a broad range of healthcare providers for the early detection of cognitive impairment. Early detection allows patients to address modifiable risk factors sooner, potentially changing the course of cognitive decline. It also allows healthcare providers to develop a plan with the patient and caregiver so the patient can live their best life during their journey. For more information, go to www.cognivue.com. That's www.cognivue.com.
Hello, everyone, and welcome to Caregiver Chronicles. My name is Sarah, and today I have Timothy Poore with me. Timothy is a placement specialist and CEO, founder of ATP Healthcare, a company that specializes in finding discharge placement for patients with complex needs. They typically work with hospitals and healthcare systems and also families. Hello, Timothy. How are you today?
I'm doing great. How are you doing?
I'm doing fantastic. Thank you so much for taking your time to chat with me today. Would you like to further introduce yourself to my audience?
Yeah, so we, it goes over, we do assist in finding placement options for patients, typically with hospitals or health systems. We do work with families from time to time, but the vast majority of what we do is actually with hospitals. And so we get sort of like a behind the scenes sort of like, look behind the curtain on some of the issues that are taking place and with healthcare today. And so we try to get a pretty accurate information on what at least what we're doing as far as our decision-making process is going. Well, we just want to make sure that people understand that we're not, we're not like a for-hire dumping service that will take patients and just say, oh yeah, I got an address of a bus stop somewhere. That's not what we do. We work with hospitals and health systems to find appropriate placement options for those challenging patients. So usually when a hospital system's working with us, they're doing everything they can for the patient.
Awesome. Thank you so much for that. And what made you realize that there was a need for finding placement for people after a hospital stay?
When hospitals were willing to pay us. So I worked in post-acute care. I did a tour of duty and hospice and home health, and then I worked over in skilled nursing for a brief period of time, and then I ended up working for an investment group that purchased skilled nursing properties across the Southeast mainly, and then would backfill them. And one easy way to gain census in your buildings, if you're able to take in very complex patients. The only way you could take in complex patients if you could figure out how you're going to get paid for those patients, because the margins are very tight. Average skilled nursing facility, your net profit margin annually is less than 1%. And so, you have to figure, if you're going to budget improvements or raises and all that sort of stuff, is going to come out of less than 1% of what your net profit was. So you really have to kind of like, you can't screw up. And because otherwise, you take a patient that's too complex, or you take a patient who you didn't vet enough, you're going to experiencing some major losses. We had I had reputation of being able to get these patients across the finish line, and we had a couple of health systems that would call us and say, "We got this patient. I know you don't do this anymore, but could you just take a look?" And we would get some of these issues resolved. And after one particular case, the patient had been in a hospital. They were not so much clinically complex. They mostly had some criminal activity, some criminal behavior that made them a very complicated placement. Um, and this happens a lot. Obviously you have to put this in consideration, not just for the safety of the patient, but also the safety of the staff and families that may be visiting and residents of a facility. And we were able to place patients safely and with the safety of the staff and families in mind, um, relatively quickly. Patient had been in the hospital for, at that point, 62 days. And after the face-to-face interview I had with that patient, they were going to be leaving in a few hours to go spend the rest of their life at a skilled nursing facility, nursing home. So at that point, the director of care management for that hospital said, "Wow, you should charge for this." And so we put that to work. We tried to figure out a way to charge for that. I didn't want to do like on a per patient basis, because what ends up happening is people wait too long to contact you, and you're ending up with patients that are been in a hospital for hundreds of days, even in some cases a year. And so what we did was we said, okay, we're going to put a subscription service, and we're going to work on so many patients at a time. And no hospital in the history of creation of mankind had ever paid attention to that number. If the number was 10 max, they would send 40. So, I mean, which is fine. I mean, that is what it is. You just, you try to figure them out best you can, and get at least three options for placement for the patient. That's what you want to generate. But if you're not able to generate at least three, you have to really show why you can't come up with at least three numbers. I mean, three facilities, or three appropriate discharge options for that patient. And so that can be a challenge sometimes. And in fact, it's about 50-50 on whether or not you're going to come up with three or not. So
Yeah.
it's, and as you're probably well aware, in a skilled nursing arena, there's certain safety measures and equipment, and all the skilled nursing facilities, they have to be able to be accommodate patients the same way, but not all of them do. And you just can't just randomly pick and choose and say, okay, well, there's a vent patient who requires a high level of respiratory therapy. We're going to go send them to this facility right down the street from you. That doesn't work that way. There's only so many of those buildings available, because the amount of care that's involved and the reimbursement for that care just really isn't there across most states. It really isn't there. And unfortunately, those are the patients that really sort of need it. And we're seeing an increase in those numbers of patients. But, since 2016, the average patient complexity has increased by about 22%. That's going to continue on until 2030. And 2030 is kind of an important date, because that's when the last of the baby boomers turn 65. A couple of years after that, about 2032, is when we're going to start to see the first round of millennials, which is an even larger group than baby boomers, but the first group of millennials start to turn 50. And those are sort of like points along the way, along the care continuum, where you start to see more and more health issues, more complexity in patients as they get older. And millennials outnumber baby boomers by a lot, by 10 million at least. So these issues are something we kind of really have to focus on and start to address.
And that's so important because, the healthcare system isn't the most sustainable system we have in the world, in this country, just in general.
Oh,
It's
it's no longer
unfortunately,
sustainable. We did our Thelma Louise years ago. We drove off the cliff a long time
yeah,
ago.
it's just not a sustainable system, unfortunately. And there are major gaps in it. And people don't realize what these gaps are unless we're talking about them.
Yeah.
If you're the person, who has the uncle that you're in charge of his stuff, who has that criminal background,
Mhm.
you're the person who knows that a lot of the facilities aren't might not take him because of his criminal background.
Yeah.
If you're the person caring for somebody who needs the respiratory therapy and the intense respiratory care, then what that entails. But otherwise, the rest of us don't. Like the rest of the world doesn't know unless you're in that position. Um,
Mhm.
and I think it's so important to have these conversations because it's eye-opening for people. It's eye-opening for caregivers. And I know that
Yeah.
there's got to be a caregiver listening who can relate somewhere. So what are the major barriers that you see where somebody can't go from hospital to home or hospital to just a regular nursing home?
So the increasing level of patient complexity as well as acuity is probably number one. So that could be a number of issues. So like as patients are, our baby boomers are getting older, and all of us are getting older, and especially in the wake of COVID, patients are sicker and more complex, and this is a double whammy. It's one thing that's like, okay, so we're all just sicker, and that's it. But the amount of comorbidities, and I will never be able to say that right, it makes it even more challenging. And on top of that, sort of like how the payer systems are set up, it makes it much more challenging too. So, you may have a patient, we may have patient Sam over here who really could benefit from the use of skilled nursing services. However, Sam is a cancer patient. That skilled nursing facility is not the best option for that individual for that's undergoing the cancer treatment because they are palaces for infection from time to time, at least viewed that way. But if that patient isn't able to do their activities of daily living and they don't have the support systems involved, so I'm also talking here about social determinants of health. That's going to make that patient's outcomes not desirable. As that could be any more clinical term than possible. It's going to make it very difficult to have a patient that's going to survive or have any meaningful life. Really trying to avoid the setup of long-term care nursing home placement. Uh, but for many people, that's going to be the only option they have. So let's try to make this as soft of a landing as we possibly can, and try to stay out in front and stay ahead of it.
Yeah.
So those are sort of like the major roles. So we have, of course, clinical complexity and increased acuity of patients. We also have payer sources and social determinants of health. And social determinants of health is something that health systems and individuals alike can really work together and to address in their communities. And there's an immediate return on investment for addressing those in the communities. Um, it's literally like 2 to 1. So it's not the greatest investment in the world if you're looking, to do a venture capital fund or something like that. You want like 10 to 30 to 1 or something like that. But in this situation, if you're looking at, 2 times or 5 times your money back, that's well worth the community's attention. And
Yeah.
so, and making sure that individuals, they have, the basics, so they have Medicaid. Um, when we see vast numbers of people disenrolling from Medicaid, that's concerning, because at the end of the day, someone's going to have to pay for that, and it's usually the folks who have commercial insurance. That's usually who's paying for that because the health system, the hospitals, they have to make up for those losses somehow.
Yeah. And I don't, and correct me if I'm wrong on this, but I this is just something that I've noticed, and I don't know, I don't have numbers. This is just personal experience. A lot of times when a resident would come back to the nursing home or the assisted living facility too early from the hospital, too early from a hospital stay, or maybe they needed more support than we could give them. They ended up back in the hospital sooner rather than later. They kind of did this little like yo-yo thing where like the hospital would send them back to us because they didn't know what to do. They didn't have the stroke yet. And but they, or whatever it was, and then we needed to send them back because they couldn't do what they needed to be in. When I worked in an assisted living facility, we saw this more so because you need to be ambulatory. We'd send them back, they'd send them back to us, and they'd have to go back out because they couldn't stand or bear weight. there would be this yo-yo, and then they'd be admitted to the hospital for like a month. All this back and forth, and again, I don't know numbers, would probably save tens of thousands of dollars to insurance companies, Medicaids, families, and hospitals if we could figure out how to just, find appropriate placement. Correct me if I'm wrong on that, but
We're coordinating. It kind of sounds like they're a coordination of care. Could be a key issue there. And, it might not be a bad idea to have, well, let's just have a review weekly between our director of nursing and, our case management department on what we can do. What can we match up with? What can we handle in our building? And what we can have like a really sort of like honest discussion, because yeah, that's if that's a trauma center that patient's going back and forth to, you're looking at anywhere from $2,500 to $2,800 a day just in bed log issues, not being able to move that patient through the health system. That's occurring. If that's something that could just be resolved just based upon better communication, the hospital doesn't want to keep that patient for some reason, and they feel that a skilled nursing facility can take the patient, right? There's no reason for the hospital to keep the patient. They're running out of codes. So, that's something that needs to be addressed. And so, yeah, continuity of care, it needs to be spoken about, a come to Jesus conversation.
yeah. I've just seen that in my experience, or even having to go to a facility that maybe wasn't appropriate while they're waiting for a facility that's better. And just the cost of moving somebody with complex needs, or
Yep.
is intense also. Is there anything, I know you mentioned like, but can facilities have conversations with hospitals and with families, and like can there be like a representative from all three places to team up and say, hey, this is how
There
we
should
can best
be.
serve this person?
They should be doing that. They should be having a length of stay meetings that are safe areas that people can speak, you know, honestly and truthfully about what's going on in their respective buildings, what their pressures are. That does need to be happening. That's a challenging environment to create. We want to move those patients out. We don't want to be in a situation where somebody's saying, "Why did you send us this patient? You told us this patient was weanable off of a trach, and they're not," and that type of deal. I mean, you have to realize the hospital's trying to get the patient out. They've maxed out what they can do. It's up to you now. Maybe that patient was weanable, maybe they weren't, but it's still you own it. And
Yeah.
so they can't have the more like, you did this to me type of attitude. It really needs to be how can we best serve each other? And what services do we require from each other? Because it goes back and forth. Um, the hospital needs certain services. We're going to need, let's say, peritoneal dialysis or something like that. But the facility also needs X, Y, and Z too. And it really comes down to Medicare or certain payer sources. They really need to let each other look behind the curtain and see what's going on, and address those issues. And not don't make it sound so rosy and so like, oh, everything's great. Our residents love it here. Never had that before in my life. Whenever I work buildings and I would, talk to people about our buildings, I'm like, the first thing you're gonna do when you pull up, you're gonna say, Jesus by a bush. Like, right? I mean, it's like we're not there to be, glamorous, and it's not like we're not trying to make it like a landlocked cruise ship. It's a nursing home, and I got a really good nurse that's going to do her damnedest to keep you out of the hospital. That's what it is.
Yeah, sometimes it's the best you can do.
Yeah.
And again, payment is a concern too, because there are some facilities that don't take Medicaid now. And
Yeah.
you
Yeah.
know, private pay is a big deal, and private pay is, more than most people can afford.
Yeah. So if you're a Medicaid accepting facility, and the cost of labor is going to be, it's not going down, and the increase in Medicaid isn't really matching it. That's a challenge, regardless of state of what the political affiliation is of that state. Most states are having trouble keeping up with this now. let's say you're in the Southeast and your average, so you have skilled care that's going to be covered under Medicare, Uncle Sam, right? And then you have Medicaid, and Medicaid is a lot of Uncle Sam money that's involved in that, but the state has a little more control on a day-to-day operations, and the state can put some money in that too. But that's going to cover your long-term care. That's going to be your day-to-day, your room and board, some medications, some restorative therapies, that sort of stuff. But they pay like a rate. The typical facility is getting between 180 to I think like 225 a day, even under managed Medicaid plans. And that's to care for your loved one or you, right? So that CNA is $17 an hour. That there's going to be a CNA on board all the time. Doesn't matter. That LPN, there's at least going to be one LPN if there's per 40 residents, right? Pretty much all the time. So where are they running at? $45 an hour, right?
Yeah.
It's something like that. Then you get your DON and so forth, and all these things cost money. And then you get your support staff, right? You get that admissions director is making 60, 70, 80, $90,000 a year. It's like they make it because they're all supposed to be bringing in the Medicare, but that's really tough. So at the end of the day, even food services, what we were looking at on how much money we had left over to feed our residents was, you're looking at $10. Now, food is medicine, okay, right? And and if you're not getting it from Medicaid, well, then you could say to yourself, well, we just go straight and make it private pay. And if you're going to do private pay, then you're going to be looking at, okay, we're going to be the more in line is going to be about $300 a day. That's going to be more in line on the nursing home side, essentially double what an ALF would be, because you are getting a lot more contact, clinical contact, license contact at least, at that level. And so that seems to be a little more of that seems to be an option that more facilities are going to. And yeah, if they're spending it and they're spending it on stuff like on food and on wages, that's what's going to make the biggest difference for those residents. But at $300 a day, you can't afford that for too often. For
Yeah,
too
bank accounts drain fast.
very.
Absolutely.
Oh yeah, I mean, so in the facilities that I oversaw, I can count on one hand the number of private pay patients we had. We may had a couple that would spend down, right? That they'd be a little bit over asset, but that spend down was probably about a week or two. It was quick. It's like it's gone, you know. So that's a big challenge, really big challenge. Nursing homes have no problem racking up bills for people.
Yeah. And I mean, again,
Care's
they do have
expensive.
to pay their staff,
Yeah, care's expensive.
the CNAs have to live too. And that's not an easy job. I did it for a long time. I will tell you, it is not an easy job. It's
There's a private pay skilled nursing facility. It's a long-term care, and I think their top end price before COVID was $2,800 a day. You basically have to be like well, yeah, you have to be a millionaire too.
you have to be rich. Yeah, exactly. You're that's not going to be where I end up most likely. Um unless there's like
Country
a
boards.
massive
They
change in
have
my life.
goat farms out there, and there's staples, and
Yeah.
they have transitional rehab facilities there. It's just gorgeous. 160 acres, gorgeous place. But yeah,
Yeah.
it's $2,800 a day.
Yeah. I'm not surprised. Again, I worked in some upscale long-term care facilities and they were beautiful and the staff was treated well and the residents were treated well and everybody had the best care and it looked great. And when you go into the places that accept Medicaid and it just smells like pee. And I'm not, and oh my God, I just want to make this clear for everybody listening. Please know that I am not being a snob when I say this. There is such a difference in the facilities in just how
Yeah,
they're run and everything else based on that.
yeah.
If
I
all
mean,
you can do is put your loved one in a Medicaid facility, then that's the option that you have, and that's what you have to do. be there every day for them and support them. But if you can afford and you're lucky and you can afford this nicer facility, by all means go for it. But
Oh,
there's
yeah,
difference.
this isn't like well, I'm smart and it's not going to happen to me, or I'm connected and it's not going to happen to me. So one case we worked on was with the hospital system, and hospital reached out to us, and I'm like, I mean, there's only like a few options nationally for placement for this patient. They had a very the pulmonary fibrosis is very advanced. The family wanted skilled rehab. I'm like, really, what's the outcome that we're expecting here for this type of disease? Because it's a continual constriction of the lungs. And the patient at the time was on 63 liters of oxygen. So that's what's keeping the lungs open. That doesn't mean it's like you're like hyperventilating. That's what's being used to keep your lungs functional. That's the amount of force that's having to go through. This is very, very challenging. The the spouse of the patient, without disclosing the whole lot, was a state representative. They had been a state representative for 20 years, and they served on healthcare committees. And there's like, what do you mean there isn't a placement option for for their loved one? It's like what the hospital is recommending is like, I would take it, because you can't place this patient into a skilled nursing facility. It's just not going to happen. This is the route that you're going to go. You're going to be looking at Texas, Minnesota, and there's a community that's in Georgia. And that's basically it. And they had other needs, clinically complex needs. So we're essentially looking at swing bed facilities on the small end to academic centers who are conducting a long-term trial, and they can potentially house that patient. That's the options they're looking for. It's really the patient's really appropriate for hospice at this time, and you really have to have that conversation. But they were dumbfounded that there wasn't options for families. I was like, our company exists because the options are so slim that hospitals have difficulties working with their providers and their network to meet the needs of the patients that they need. Like that shouldn't happen in a million years. There's no way there's a health system that's healthy if that's what's taking place.
Believe that
You-
nobody should be discharged from the hospital and thrown on the street or just sent to somewhere inappropriate. And there's just such big, like you said, gaps in especially when it comes to hospital to whatever's after it. If it's long-term care, if it's home, if it's assisted living, what if it's skilled nursing, if it's a hospice center. There are options, but they're, like you said, they're limited, they're small to come by. I know in my home state there's only one hospice center, and there's a waiting list, and it's so funny because there's like a 3-month long waiting list to get to get into a hospice center, and a lot of the people who are on hospice don't have. I laugh. This is
No.
not.
Yeah,
You
if the care center
you don't
appropriate,
have it.
you don't have 3 weeks. You don't have 3 months.
Yeah, the patient doesn't have 3 months,
No.
and so it doesn't make sense. So what do? They discharge. I've seen a lot of cases where people have been in their long-term care facility, like assisted living, and still have to pay for private pay CNA to come in and be there all day, or even in a long-term care where they have to hire a special person to come in and be with that person one-on-one because they need that support and they just don't have it. So the family still has to pay this out of pocket extra
Yeah.
expense, and it can ruin a family. It can ruin, you lose your, again, there's only so much money that people have that, when you're spending $100 a day on care, or whatever it is, 300, 500 thousands,
Yeah.
you're gonna run out, and hopefully it doesn't affect your mortgage and your ability to buy groceries in your future. But
Or
it
your
can.
relationship with your loved one, right? Because that's like that's really frustrating. That's really puts a lot of guilt on all parties. Like, you don't want to be that burden that's causing that. If it's you, right? Well, at least I wouldn't want to cause that burden on somebody. And on the other side is like, I don't want my kids to be sitting there having to deal with my shit. You know, it's like, and that's really it's very stressful. And so we both seen this, especially on the nursing home and the ALF side, how much do families actually come in and visit? It's not that often. Again, I can only think of a few families that came and visited residents. Now, granted, I was, traveling amongst buildings pretty often, but, over several years, you get a pretty good idea, and that's very few. Yeah, and a lot of that is that stress, that's, been built up for, whatever, 40, 50 years, whatever it may be, on with individuals in their care and what's available, and how close and supportive is family. Those are all challenges, and those also go into that social determinant side. And you start to say, well, nursing home placement may be the best option for that individual, because at least they're going to have that continuous social contact. I tell people, like, people would say, "Oh, I only want, and they live like 1,000 miles away. I only want a private room for my mom." I'm like, "Well, that's great. How often are you going to be here? Just hang out with your mom in the private room, because we really need her to be, interacting with people. She needs, having a roommate is a great thing because family isn't there that often. There's not. You do have your other responsibilities you got to take care of. It's just too much. And so, right, and that's kind of like makes people kind of open up. Our buildings were old school. They were built in the 70s. We got quads. I mean, it's 4-door room. And people, like, families would freak out. Are you kidding me? It's like, I mean, it's like high school. This is like a slumber party. It's like, I mean, they were like, now you can't do that anymore, of course, but they were having a blast. All new residents went to, one of the quads, and basically the ladies or the guys who've been there the longest would kind of, teach them the ropes, and that sort of stuff, and then we would match them up with the appropriate roommate, when that became available, and that was always fun.
That's a whole other conversation.
Oh yeah, I mean, yeah, when you do your midnight check on your building and stuff like that, yeah, you check on that room. That room's having, I mean, they're all like, they're sitting there watching TV. I mean, there's one group that the guys were a little bit younger. They're like in their 60s and stuff like that. And one of them had a PlayStation. They're all like playing on PlayStation. They're like 60-year-old guys playing on PlayStation.
Hey, there's nothing wrong with that,
No, but yeah, I mean, yeah, they're playing like I think it was like Battlefield or something like that. I
But
was like,
we're gonna see more of that too. Is like
oh yeah,
'cause the younger boomers aren't anti-technology, like the younger part, the older
yeah,
ones a little bit, but the younger ones not really. And Gen X, I mean, they invented video games. That's
yeah.
that's what they grew up with. And I'm a millennial. My generation, I still play video games. I'm almost 40. I'm a woman. I don't care. Like they're for everybody.
Yeah.
Um, we're gonna see more of that in facilities. We had the Nintendo Wii
Oh
in one
yeah.
of
Oh,
a few of the
there
facilities
is
that I worked
a
at.
building that doesn't have that, right?
The
Week
residents
bowling
loved
night.
it. They had so much fun. They thought it was the coolest thing. They laughed, they could play games with it. It just and it's awesome. I remember we had a lady, she used to order every week spaghetti and meatballs for her and her roommate from the local pizza place. They would bring her baked ziti and meatballs and she'd split it with her roommate every week. And I remember in long-term care, roommates could be a good thing and they look out for you,
Yeah.
you know?
Yeah. And they know
Um,
if something's not right, or if someone's not being treated right, right? And they'll respect, and they can help with that too. And so you have that extra reference. I got one more story on this. That we didn't give very many tours for our buildings. Just there wasn't a whole lot of demand for it. So I only did it a few times, and this one time I did this tour, and we always had, I mean, we had like one of the streaming services for our multifunction room, cafeteria, events, all that sort of stuff. And they had it on, they were watching Predator when I was through a tour, and it's like blasting, and like the whole, like, I mean, there's 48, 50 people in the room. We're like a 60 bed facility, so it's basically everybody's in there and they're just like screaming and hollering and, and all the course seems I'm trying to give like a tour of the building. It was fantastic. I don't never saw them again.
I love it though. Listen, like, I have resident they want to watch the horror movies. They want to watch,
Mhm.
around Halloween, they want to watch the gore, even in the facility that I'm in now. One
Yeah.
lady said to me, she goes, I'm getting sick of war movies. She goes, I want to watch like an action explosion movie that's not war. I'm like, okay, cool. There's this sweet little old lady saying this to me, and I love it. I giggled. I'm like, I'm with you. I'm
Yeah.
like, I know when I watch a movie, like it either has to be hysterical or things have to start blowing up right away, or I'm out. Like I'm, it's got to be one or the other.
I no, I'm the worst. You don't want to watch a movie with me. I'm like the type of person who like I'll watch a movie and it's like and it has to be something that's gonna like change the way you think about life or like really make you question how things work or something like that. I can't. It's just I'm annoying, and then I'm bringing up things. Oh, in this scene. That's me.
But
Sorry.
that's
I
okay.
digress. Sorry.
And no, it's fine though. But like our residents, like nursing home residents and long-term care, they're people. You know what I
Yeah.
mean? They're not just like this innocent old person. Like most of them have some kind of background story or some kind of life they lived. They have preferences. I have residents who love rock and roll music. Or hard rock. One guy was a fan of the band. I think it was Korn he liked. And he was like, he was listening to them one day and I'm like, you like this? And he goes, yeah. He goes, it's Korn. I'm like, yeah, I listened to this when I was a teenager. Like, you know what I mean? And like, I was like, it's pretty cool. Like,
Yeah.
and he was goofing on me. He's like, because to him, I just look like this bubbly, all my nursing uniforms, all my scrubs were pink. When I could pick my own color for my scrubs, everything was pink. So I'm just like this bubbly pink little girl, and he's like, you listen to this? I was like, wait a minute. And I'm like, well, he's like, you don't look like, I'm like, well, you don't look like. And we just chuckled, but it's so true. It's like people are people. We forget that when our loved ones end up in a long-term care facility, even if there's parts of them that have changed, they're still themselves. And we have to remember in facilities, and again, you're talking profit margins and money because the bottom line is important, but facilities have to remember and figure out how to accommodate and work around and keep people happy and safe. Safety is important too,
Yeah.
all of the above. How do we do this? It's a very tricky thing.
Yeah, it is. It is. So, if you have a loved one, there's certain things you're going to want to talk to them about. Advanced directives, what do they want, if things should go south. And it's always a fun conversation, I know. But also power of attorney, durable power of attorney, who are the decision makers? You want to get that down as as solid as you can. I there are things that you can go online and go and download. I do not recommend. Sit down and just have a consult with an elder law attorney for just a few minutes. They're most likely going to tell you and point you in the right direction, whether or not, you can go that route in your state. But also you need to be looking at trusts in order to assist with any spin down issues that may happen with your loved one if they're going to be over assets as far as Medicaid wise. And if that's the case, then you're going to need an attorney for that. And then they can also work on that Medicaid application too, because at the end of the day, for the vast majority of us, Medicaid's going to be the payer. The overwhelming vast majority of us, Medicaid's going to be the payer. And that's not just if you're going to be in a nursing home. That's also if you're going to be like, I'm never going to a nursing home, I'm going to stay here at home. That's fine. Most states now have, long-term care plans or portions of their policies to help deliver care for you at home. And also there's, hospital at home services that do pretty well. They can handle a pretty high level of acuity for patients at home. They almost like the step down levels, right? I mean, they can do really high level stuff. So, and those are actually much cheaper options than nursing home typically. It's just not available for everybody. I want to make sure you have your decision maker in place. If you get to an event where your loved one, your loved one, or visiting the hospital for whatever reason, case manager is your best friend. That you want to share and be as open and as honest with that case manager as possible. Even if you're having fights or arguments or whatever with your loved ones you're taking care of, or if you're just be honest with them on what's going on, what are their preferences, all that sort of stuff, and make their life as easy as possible because that's the producer of the film. They are the ones who is organizing and keeping this movie, who is starring your loved one on budget, on time, and off to its premiere as soon as possible. When that person gets bogged down and is having to do 15 other things, you know, quasi related to, developing the plan of care for or keeping that plan of care on task, that's when things go south. That's when things get missed. Okay. And it also has an effect on other patients as well, because they don't just have yours. They probably have about anywhere from 25 to 30 other patients that they're working on at that moment. Right. So that makes things pretty challenging. It's a tough job. It's by far, I would say, it's probably one of the harder jobs in the hospital. A lot of things juggle in the air, and you build a rapport, and you can speak very honestly and openly about what are the actual genuine options and what really should we be thinking about as far as care wise goes, and they can help with that, whatever it may be.
Thank you so much for that. And I think that that is great advice. I am a huge advocate for get your affairs in order early, even if you don't plan on going to a long-term care facility. Tour them and figure out like what ones you may or may not like. Get on waiting lists. Even especially, these are just things that I'm a huge advocate for because even if you don't have that in your plan and something happens to your caregiver and you can't be, 24-hour home care isn't an option for you, try to get stuff figured out. So at least there's an idea or a plan. Always have your plan A. I'm going to stay home or I'm going to go to this facility, but make sure you're ready for B, C, D, E, F, G, all the way up to Z. Um, just plan for several different scenarios to play out when you're making those plans. I think that that's so important. I want to ask you, we're kind of getting to like the last few questions here. What is your favorite form of self-care?
A long time ago, we used to play tennis. Really like doing that. Haven't done that in several years. So, in full disclosure, been with our company, we've been working on an AI platform to assist hospitals in identifying patients early on, essentially upon admission, that are going to be requiring post-acute care, and then the AI platform actually stays with the patient throughout the recovery journey into the post-acute care arena, either into long-term care or back to the primary care physician. So it works with really maintaining that continuum of care for the patient. And that's been for the past 3 years now. That's been my leisure activity more than anything else. And that's but that's what I did in the past, and that's what I'm looking forward to doing in the future. Once things start to get a little bit more settled down.
Well, thank you for that. And when that AI platform is like launched and ready to go, let me know and come back and talk to me because I think that that's, healthcare is the world is heading in that direction.
We're
Um,
just we're just waiting on the ink to dry for our first two health systems right now.
oh,
So
cool. Well,
yeah.
let me know. I would love to have you back and to talk about it more. And then my final question for you, where can my audience find you for more information?
Yeah. On the interwebs, you go on there and you type, and it's going to be atphealthcare.com. And you can connect to us on the website, or you can just give us a call, and that's going to go right to me. I don't save phone numbers, okay, because I never know who's calling me. That's always fun. But especially if you have any questions regarding your loved one, complexity of care, criminal background. I know we kind of discussed on that on the pre-interview for quite a bit. Yeah, there's a lot of issues in that arena, and we can give guidance on that, and at least get folks pointed in the right direction. We can be hired, but most people, all they just need is just a discussion about it. Okay, just do X, Y, and Z. Let me know if you're going to need any help later on in the future, and best of luck to you.
And even though you're based in Florida, you do support families and work with facilities nationally, correct?
Yes, nationally, yeah, and we're actually working on the international side too. We're reaching out to other countries outside the United States. So this is length of stay is an issue that has pretty broad reach.
Yeah. So this is not just a United States issue. This is a global issue.
Yeah, yeah. There's only so many beds,
Yeah.
right? And they're not cheap, and that's what we're facing now.
Awesome. Well, thank you so much. We're kind of wrapping up time here, but thank you so much for your time and chatting with me. I want to remind my audience, my listeners, that if you liked this episode, you could support our show by sharing us with a friend. You can follow us and like our social medias and subscribe to our social media accounts. There is a link to buy me a coffee on our website, stelmachbrownmedia.com. I understand if you can't monetarily support us, but the best way to really support us is to share this episode with a friend. And with that, I want to wrap up this week's episode of Caregiver Chronicles. Thank you for listening, and I'll see you next week.